السلام عليكم ورحمة الله وبركاته. Good evening, Professor Lou.
Good evening.
Good evening, Nancy.
Good evening.
We can't hear you, Nancy.
Good evening, everyone.
Good evening, Nancy.
Good evening, Mr. Lou. Good evening, Dr. Sanjab.
Thank you. You're welcome, everybody. So still we have 2 minutes to start. Thank you, Professor Lou, for joining us. It's always a pleasure and honor to have you, to learn from you as well.
It's my pleasure. Thank you so much.
And Merry Christmas, by the way.
Merry Christmas.
Dr. Mazen, are you here? I think he lost connection. Are we going to, I just prepared like 2 or 3 slides. Would you like just to start with that and then we do the polls or something, or the questions?
Yeah, the polls are ready. So whenever you ask me to do so, I'm ready.
Okay, great.
Professor Husni apologized because he has an family occasion that there is a wedding for some relatives. So maybe he can join us, maybe. So shall we start?
Yeah, I'm ready. I can share my screen.
Yeah, let me allow you to share. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Everybody, you are most welcome to the last but not the least lecture in the 2021 series in the to the Wonderland series. I would like to thank, I would like to have the opportunity to thank Dr. Nancy and Professor Lou, of course, Dr. Muhammad Husni, for giving the time, for organizing the talks during the 2021 year, and for helping in the 2022-23, the 2-year series of To the Wonderland series. Thank you very much for your time, for the science that you have taught us, and for everything, for the support to Sanjab Academy. Of course, we will learn today how to show respect from Dr. Nancy, who is really professional and masters this art very well. Thank you, Dr. Nancy, and the stage is yours.
Thank you very much, Dr. Mazen. Actually, we decided to make this session, since it's the last one in this year, to be interactive and kind of not that much scientific, to push some knowledge back and forth between the audience and ourselves. And before that, I would like to thank you, Dr. Mazen, for allowing me and giving me the opportunity and the platform to be part of this very educational platform or academy, and honored to be with my mentor, Professor Lu, and for Dr. Hosni to be able to join us through most of the sessions. And I remembered today, last time you called me, it was like almost a year ago when we started to thinking of this series. Do you remember? And really, time flies. Now we're a few days away from the new year, and I hope we were able to give or change any kind of practice that has been mispracticed or it wasn't very clear for the general ophthalmologist and those who are interested in this knowledge. And I'm here to, because this is the Cornea series and it is all about the cornea, we decided this topic to be the last because showing respect for the cornea, especially a grafted cornea, is not because it's the mostly grafted tissue. It's because we need to show respect to all the teams and the people behind this transplant and what it represents. It represents the grief of the diseased family. It represents the hope for mercy from the ones that we lost. It represents the future for somebody who is blind, and it represents a savior for this who is in need and sick. And it is also a precious organ to get, especially in less developed countries, let's say, and those countries where resources of organ donation are not as much well established. So I'm sure everybody tries his best to save a clear cornea, and but maybe sometimes when we look at it in a different kind of angle, different kind of way, it changes how far we would go in our treatment in order to maintain the clarity of the cornea. Now, just a quick introduction. We all know a transplant can be any part of the cornea. It's mostly a penetrating keratoplasty that transplants the whole tissue, or it could be a deep anterior lamellar, an endothelial transplant, a decimal membrane transplant, or an anterior lamellar keratoplasty. So any type of replacement of corneal tissue is a transplant that we have to take care of. Okay. And let's talk about numbers before we go into the polls. Penetrating keratoplastic graft survival rate is 91% at 1 year. It's 72% at 5 years and 69% at 7 years. It's the most successful organ transplanted. And the three most common indications are keratoconus, bullous keratopathy, and then a redo or a failed previous graft. And the most common causes of graft failure are a rejection, an infection, and glaucoma. And these are according to different studies. And I would like to ask Dr. Mazen to start the poll so we can have some negotiation about different questions and see how you think about it. Dr. Mazen?
Yeah, sure, Doctor. Launch. So, dear audience, you can start immediately, and they are actually 8 questions, single choice. So you can start now. We'll give about 3 minutes, maybe enough. 4 minutes.
Oh, that's good.
Meanwhile, may I ask Professor Liu, what is the most common cause for corneal rejection, graft rejection, I mean, in penetrating keratoplasty, in your practice, I mean, and the most cause for graft failure, the most common cause based on your experience?
Do you mean the reason for grafting or the actual mechanism of
rejection of the graft, the most common reason of rejection and the most common reason of failure?
Well, rejection, I mean, I think in high-risk keratoplasty, when there is pre-existing corneal vascularization, especially devascularization, or where that been previous grafts, previous rejections, the larger the number of grafts you've done previously, the shorter the survival of the graft. And in terms of pre-existing condition, I think herpes simplex is highest risk, and keratoconus is low risk in terms of penetrating keratoplasty. And in terms of specific causes, I think when there is a loose suture and that's not attended to, then it can cause infection and graft failure. And also, I think premature cessation of steroid drops. I mean, I think it has some bearing on the answers to the questions. Some surgeons will say steroid drops actually need to be used indefinitely, but of course, I mean, the other possible answer is on a case-to-case basis. In terms of failure, it's either the graft is of poor quality to begin with, but that actually is not very common because the good eye banks will have quality control. Sometimes I know that when you have to purchase graft material, the slightly time expired ones and the lower quality ones, they will be sold for less money. So that's one cause. But a lot of it is down to the surgeon not being careful and respectful to tissue handling. And of course, any cells, endothelial cells which come off or get damaged or from chronic inflammation do not survive, then that would result in failure, which of course, if there are not enough cells, then the graft has had it and it's not going to recover. But of course, nowadays, it's possible to reline a failed penetrating graft with a DMAC underneath, and then you retain the corneal shape, which the patient may already be used to with glasses, contact lens, or there may be a toric implant already within the eye. Then short of changing a corneal graft, which also changes the refraction, relining a PK, if there is little or no stromal opacification, would be my choice. So I don't know whether that answers part of your question.
Yeah, thank you very much. I appreciate. So we can stop the poll, and we can see the results now. Share results. Great. So for the first question, when to respect a rejection, any change was the most answer. What factors affect graft survival? Almost, let's say, cause of transplant, and second comes host bed. Role of steroids to treat rejection. First line, oral steroids. Next to that comes intravenous steroid, crucial. Number 4, till when to use steroid drops. The most answer option, let's say, according to case. Immune suppression to treat or prevent rejection. Both. Removal of sutures. Let's say almost equal answers. starting 9 months according to refractive outcome, and after 1 year, when to give up on failing graft, never 2 rejections, and by mistake, there is something, choice 3. Okay. Difference between failure and rejection. Failure is irreversible. So yeah, Nancy.
Yeah, I think the poll just shows how much there's a variation between different practices, how we look at a corneal graft. And actually, this is important. This is important why we're discussing this. I'll take, if you allow me, I'll take every question as an introduction to talk about what is supposed to be done. So when to suspect a rejection, this is one of the things of the instructions that should go with the patient. So one of the instructions as don't rub the eye, don't no heavyweight lifting. You tell him or her that any change in your status, like to the worst, of course, not for the better, which is any pain you feel, any abnormal sensation, any decrease in your vision, any change in the color of the graft, anything that you see, you should contact me immediately or come check into the clinic or the emergency immediately, because this might warrant a rejection. So we might be exaggerating in this, but it's better to be exaggerating than to be too late when it comes to a rejecting graft. So any change, this is a very correct answer. Any change should bring the patient back to the clinic who has a corneal graft in his eye. Now, what factors affect graft survival? Actually, it is multifactorial, as Professor Liu has just highlighted a few minutes ago. A lot of factors, they play a role in the graft survival. Most importantly, it is now what makes the cornea a very successful organ to transplant is that it is an immune privileged site. So vascularity is something that we don't want, because this will pull in inflammation. So the more vessels are there, regardless what the reason is, herpetic keratitis, limbal stem cell deficiency, whatever is the cause of the neovascularization and previous infection, this causes or jeopardizes the graft survival. So all three, the age of the patient, this is when we talk about the younger, the more risk of rejection, because it is the immunity is much more stronger in the young, and that's why in pediatric keratoplasty the rate of rejection is very high, and the vascularity just pulls in so quickly, and we tend to postpone grafting. So we can just take the three answers combined together. The other question is the role of steroids. Now, to treat rejection. IV a pulsed methylprednisolone or an IV methylprednisolone is very important in the initial stage of rejection, because it suppresses the immune response. Now, the oral steroids, they do not, or especially in the acute stage, they do not act as well as the IV steroids, although the topical treatment is the mainstay of treatment. It's you have to increase or top up the topical steroids to almost 1 hourly at first, and then you taper it. But you combine it with IV methylprednisolone, if this is not contraindicated in the patient, of course, because this bombards the immune system just all of a sudden, and allows the cornea to the immune reaction or rejection to settle down. Now, how we give IV steroids, my protocol or the protocol we use in our department is 1,000 or 1 gram methylprednisolone, and we give it to the patient over half an hour for 3 days, which is a pulse dose for day 1, day 2, and day 3, and then we tend to see the patient, and we continue on topical steroids, of course, 1 hourly tapering it. So this is the protocol. You don't start a rejection with oral steroids at first, because it takes a longer time to withdraw a rejection, let's say, rather than compared with an IV methylprednisolone. Do you have any comment, Mr. Liu or Dr. Najab?
No, I think it's all very good. Yeah, keep going.
Okay, so till when we use steroid drops, for me, it's either indefinitely, or if the patient is very old, I would stop it because I'm not very concerned about a rejection. So I'd rather choose indefinitely, even if it's once a day. Now, the common practice is that most of the steroid drops are cessated at 1 year, after 1 year of transplantation. And I'm not sure why 1 year. Maybe because the stitches are taken off after 1 year. I'm not sure, but the graft is there regardless of the stitches. So 1 year is not an answer. According to case, and what we meant with this, now the older the patient, now 70 or 80 years old, tend to have a compromised immune system. So they do not mount a rejection that often compared to those young. So a young patient, I always say, from day one, I say that this is your companion for life, even if it's once a day. And I keep them on this unless there has been any complication that I see, and I switch it or prematurely. Now, and I'm talking about penetrating keratoplasty. In the case of a deep anterior lamellar, a DALK, I usually stop it earlier because the endothelium is preserved for that patient. So I can ask the patient to stop the steroids earlier than, sometimes earlier than a year, if everything is going well. Do you
Nancy,
give them indefinitely, Christopher?
Yes, I think with steroid drops, I think I would add that, when there is any suture manipulation or suture removal, it would be an idea to up the steroids back to 4 times a day for a fortnight, just to cover that time to reduce the risk of inciting a rejection episode. And also now with COVID vaccination, there is talk that COVID vaccination can increase the risk of graft rejection. So I don't know how strong the evidence is at the moment, but I have been telling my patients to increase their drops to 4 times a day for a fortnight, from just before getting the vaccine to the fortnight afterwards, because there are reports that graft rejection can happen after COVID vaccination.
Yes. Yeah, actually, thank you for mentioning this. And I think this is where I learned it from, that even if the patient was like once daily on steroid drops and you decided to take off any stitches or remove them, or it is cut, you wanted to pull them out, it's important to top it up to at least 4 times daily, as Professor Liu just mentioned, for a fortnight, and then go back to the previous regimen. Now, we've been actually avoiding the vaccination with our grafted patients, especially those with recurrent rejection. I did not think of topping up the steroids. This is an idea actually to go back to. They have been exempted from vaccines just for the time being. But it might be a good idea to top up the steroid drops while they get the vaccine. We might think of that. Thank you for mentioning it. Okay. What about removal? Okay, immune suppression. Surprisingly, immune suppression, and there are very few immune suppressants to treat rejection of a corneal graft. And unfortunately, they do not treat a graft. They prevent a rejection by decreasing the immune response of the host. So you don't treat a graft with cyclosporin alone as a first agent, because the efficacy is not as much as a pulsed methylprednisolone or effect on a rejection. So the mechanism by which immune suppression, and let's talk about cyclosporin, which is the mostly used drug for treating suppression, and rejection. And what I mean with cyclosporin is systemic cyclosporin, because topical cyclosporin is not that much established evidence that it can affect the rejection in corneal grafts. So what it does when you combine steroids with systemic cyclosporin is that it curbs the immune reaction of the host, and this gives time for you or for the treating physician to treat the cornea or the patient well, and so get in control of the immune response. So it's not a first line of treatment. It cannot replace steroids. It might have the same efficacy if you use like tacrolimus, not that cyclosporin, but not as effective in the acute stage. It might be effective in the chronic stage, and it prevents rather than treats a rejection. Now we come to a very important topic, which is the dealing with the sutures in a corneal graft. A lot of patients, they just move back and through between clinics and between the optometrists if they need contact lenses fitted, because there's an idea that the stitches have to be removed at 9 months. And actually, this is not very true anymore. Now, what we do at our practice is that we remove stitches according to the patient's age and according to the refractive outcome. We assess how effective are the stitches. We do this is in penetrating keratoplasty and DALK. We do interrupted sutures. Now, whatever I'm talking about is not applicable on continuous suturing. So this is for the interrupted. We do a refraction and a pentacam, a topography for the cornea to see how it's going. So if there is a high astigmatism or the cornea is too steep or too flat, then we have in our mind that we give it some time. At 6 months of the corneal age, let's say, we will arrange a revision. And a revision means we will adjust the sutures. We either, if it is too tight, we just replace it with looser stitches. Or if it is too loose, we replace it with the tighter stitches. So we steepen it or flatten it according to the refractive outcome. And if there's a high astigmatism that's only in the meridian of 2 sutures, that we can rid the patient from like -11 to -2 in just removal of 2 stitches or replacing them, we just do that as early as possible. So regarding the refractive outcome, we do not stick by a rule when it comes to adjusting or removing stitches. Now, and then after, let's say everything is fine and the patient has only -3 myopia with -6 astigmatism. Any astigmatism that is above -4.5 is managed by removing of all stitches. So we plan to remove all stitches after between 6 to 9 months onwards, because this will affect the visual outcome a big time. Now, if the astigmatism is below 4.5 diopters, then we do not touch the cornea, given that the spherical correction is not very high. So because there's the risk of doubling of astigmatism after removal of all stitches is 50%. So instead of settling with 4.5 diopters of astigmatism, the patient might end up with 11 or 12 diopters, and that would be will get us into a vicious cycle again. The other important factor in removing stitches is the patient's age. Now, the cornea is a very forgiving tissue. It models and remodels so quickly. So the younger the patient, the modeling rate is very high. And if you remove all the stitches in a patient who has a penetrating keratoplasty early, you will end up after a few years with a deformed, remodeled graft. And what I mean with deformed, there would be a proud cornea, there might be an edge or a dehiscence. I have seen this a lot, and I have had to go again and put some stitches again in young patients with premature removal of stitches. And what I mean by premature is at 9 months or 1 year of graft age. Now, the older the patient, again, it applies also to steroid drops. The older the patient, the less likely the cornea would remodel. So I wouldn't care about a cornea in a 70-year-old as I care about a cornea without stitches in a 25 years old, because that cornea is very modifiable, and the older he gets, it just doesn't mount that remodeling behavior. I would like to hear from your input, Mr. Liu, about this. Have you seen this?
Well, I think I agree with you. I think if we just talk about PK or PKP,
yes,
then what I do is, if the refraction is good, then I actually leave it there until it starts to disintegrate or break, because they're enjoying good vision, and we don't know what will happen when all the stitches have been removed. But if the refraction is not satisfactory, then once I know that it's healed sufficiently, you know, for that age, then I will remove all the sutures and see what there is to be done to adjust the astigmatism, either with arcuate incisions, or if there is still a lens there, a toric implant. And if the graft has some areas of proudness, then I might actually break off that area and resuture it so it gets a better shape. So that's what I do with PKP. What was it? Just remind me, what was the final bit that you asked me about?
Yeah, this is what I was asking about. If you remove all the stitches in a young patient who's do you tend to remove it in a 25 years old, all the stitches at 1 year, let's say?
No, not if the refraction is good. I would leave it in place.
Yeah.
And it is actually, my stitching is usually quite tight. So the nylon suture are all quite covered by epithelium. So if necessary, I'm quite happy for them to wear a contact lens. It's not going to erode onto the nylon sutures. So not necessarily. I think if the refraction is manageable, I don't remove the stitches or stitch if it's a single running until it starts to break, or when you look in the slit lamp, they become thinner, the suture material, because if you leave it for too long, then it's very difficult to remove as well. So there is a balance.
Yeah, absolutely. Yeah. Yeah, this is a very important message, that it's okay to use a contact lens over stitches. It does not need to be removed, because a lot of patients, they come back to the clinic saying that we wouldn't be fitted with a contact lens because there are stitches there. And the reason we're keeping stitches because they're serving a purpose. They're maintaining a refraction at a good outcome. So thank you for mentioning this as well.
But I think if they're very superficial and it looks as though there's very little epithelium over it, or if they're actually exposed and slightly loose, then of course, then the contact lens will not be a good idea, because it may increase the risk of infection.
Yes. Okay. Okay. When to give up on a failing graft? Of course, never. But you do your best and you bombard the graft with all the needed steroids, immune suppression systemically if you need to go into immune suppression. But maybe the question should be when to give up or waiting for the graft to clear. Maybe this is the way we should have asked the question. So I had patients with 10 episodes of rejections, 10 episodes, and it cleared every time. So as long as the cornea clears after the initiation of treatment, then you just go on. You give up on it if the cornea does not clear after 2 months of continuous treatment. So if the edema persists and the failure ensues and it wouldn't become clear again, then this is when you call it a failure and the rejection would not go away. And this is when you consider replacing this graft. So You never give up on a graft that rejected, no matter how many times. But if the rejection just continues beyond 2 months of continuous treatment, then you would call it an end, and then you would consider replacing it.
If you allow me, Dr. Nancy, the choice 3 here, I went back to your paper that you sent me. It is 6 months. So the choice is never 2 rejections and 6 months. Just a correction for the audience.
Okay. Now, the difference between a failure and rejection, and this is important because a lot of people just mix this up. Failure is irreversible, and that's quite true, yes. And rejection is an immune reaction. So rejection is an immune reaction that occurs usually, the graft clears at the beginning, and then after 2 weeks of a clear graft, it starts the rejection. The rejection is usually at most in the first year of transplantation. Failure, if it is a failed graft from the beginning, the cornea from its source because of the mishandling or because of there's an edema or an opacity that would not go away, it would be from the beginning of the transplantation. So failure is a non-immunogenic reaction, but while rejection is an acute immunologic rejection or a response, and rejection can lead into failure if it does not go away, as we mentioned in the previous poll. So they're never the same. One can lead to the other, but they're not the same because the way we deal with them is different according to how they present.
Yeah, great.
Now, I want to mention something before we finish talking about this. Now, it's the same topic about giving up on a failing graft. You have to just balance all the points about, do you think that this has a very high risk prognostic factor for failure? So, and you wouldn't want to wait for it like for 2 months to see because it's doomed to fail as the previous times. We still have options to rehabilitate the eye with like a Boston keratoprosthesis or a keratoprosthesis is always a choice in recurrent graft failure. And so this is why I wrote the never giving up on a failing graft and dooming the patient with no solution. Yeah.
Thank you, Professor Liu, for sharing the 2 articles. So, dear audience, you can see the link that Professor Liu have shared in the chat. Yes. Suturing techniques and post-operative management in penetrating keratoplasty in the United Kingdom. Yes, Dr. Nancy?
Yes.
Anything to add? Or may I ask a question?
No, I think we're done with the questions. So I can't move the slides. Okay. So this is what we wanted to cover. When do we stop steroids? If we stop them at all? When we remove stitches? Do we immune suppress patients? Now, one point to mention is that if you have a patient who is already who has a systemic illness like a patient with rheumatological disease or a patient who is with oculopsychiatric pemphigoid at the beginning of the disease, because the eye wouldn't be that dry at the beginning, although the corneal graft is doomed to fail and reject in these patients, it is worth giving them and starting them alongside with the topical steroids with systemic immune suppression. And the systemic immune suppression that we use, as I said, is the oral cyclosporin medication, which we usually give as 50 milligrams twice a day or 100 milligram daily. And in addition, we can use the tacrolimus, and I would like to hear Mr. Liu's input about using tacrolimus, because it has the same efficacy. We don't have it actually here. It has the same efficacy as cyclosporin, but the tolerability and the side effects are less. And yeah, this is one point I would want Mr. Liu to just comment on it, please, if you use the tacrolimus.
I don't actually use any systemic immunosuppression apart from steroid, which I can then taper off myself. If I really need anything strong and poisonous, like immunosuppression and biologics, then I would team up with a physician, usually a rheumatologist. I have not had cause to use these in very high risk grafts. Sorry for my lack of experience.
No, that's fine. So yeah, we're doing yeah, same, because we don't have the tacrolimus, and I know that it has been as effective as the cyclosporin, but I haven't used it as well. We use the skin preparation for the some patients with atopic keratoconjunctivitis in severe cases, but still it is still a harsh medication to use on the eye. I use it on the eyelid sometimes. This is just a few notes I've just put down. And the most frequent cause of graft failure is rejection, and the 30% of transplanted corneas experience at least one episode of immune reaction. And in low-risk cases, these become a failure, as we said. The incidence of rejection is very variable. As you can see, it's from 2% as high as 68%, and it depends on all the factors that we've mentioned, on the high-risk factors. As we said, topical steroids are the backbone of treatment. Now, how to handle rejection? It's very important before handling the rejection is to address any risk factor that might lead to a rejection in the host or in the bed of the cornea before attempting a keratoplasty. So if there's a dry eye, try to lubricate as much and enhance the surface. If there's a cut or protruding suture, it might invite infection or vascularization. So you have to deal with this as soon as possible. If there's a new vessel, you have to remove it from your way. There are so many ways of removing a new vascularization. Now, if a new vessel is there because of a suture, get rid of the suture or change it. If the new vessel is there because of it's harboring, because of like the initial pathology like herpes, we can use subconjunctival. I know it has been abandoned in so many places, the use of anti-VEGF, Avastin. We do still use subconjunctival anti-VEGF injections to control the new vascularization. Now, if it is a very large bore, a wide bore vessel, we tend to cauterize it with a cautery and then give subconjunctival Avastin or anti-VEGF treatment. If there's an inflammation that mounts a reaction, you have to control the inflammation with topical and systemic medications. And there's the COVID vaccine, where a few studies have shown that there is an increased risk of graft rejection. And I think, in my own simple explanation, that COVID, the pathology about COVID, of the different thing about it is that it mounts a very aggressive immune response. And this is where people just, they lose their health or succumb under the effect of the COVID. So the vaccine mounts an immune response to and it enhances the immune system or the machinery in the body. So if we click on the immune system, we're just compromising or jeopardizing the cornea as well. This might be a simple explanation. That's why we tend to suppress patients with transplantation. So the COVID does not act as a simple virus like the other viruses that with direct killing. The immune mediated pathology is very pronounced. And so the vaccine might play a role in this. Now, if the IOP is high, also this is a very important, and this would cause edema of the graft, and this should be controlled. Usually, I tend to give my patients pressure-lowering agents for the first few weeks, even though they don't have a history of glaucoma or they're not at risk of it, because I feel you need to, at the first or the beginning, you need to just maintain a lower level of aqueous influx into the cornea until the cornea just settles in place nicely. If there's a stem cell deficiency, and if you leave it not addressed, that you're dooming your graft for definite vascularization and failure, you have to address it with autologous transplants, lab cultivated stem cell transplantation, whatever is available for you. And when you go to handle a rejection, or even if you suspect it, we go aggressive. We do 3 days, as I said, of pulsed methylprednisolone therapy with increasing the topical agents until the rejection has subsided. Now, what are the signs of rejection? It could vary between different, it can come in any way, but look carefully for an edema. It's better to think of a rejection than anything else, even if it's like a reinfection. It's rather better to think of it as a rejection. Sometimes we get mixed up between if this patient had a graft due to a herpes simplex stromal keratitis, and he comes with just a stromal edema. So do we treat him as a herpes reactivation, or do we treat him as a rejection? Apart from not having any KPs, no anterior chamber reaction, no signs of descendant membrane folds, let's say, in hepatic keratouveitis. If there's no epithelial defect, then it's better to go with treating a rejection and topical up steroids, because in any type, it is an immune reaction that you need steroids to overcome this. And we also cover them with oral acyclovir, so we have 2 hands covered. Now, corneal vascularization starting to come into the cornea or encroach are also a threat for rejection. Stromal infiltrates, codado dust line, epithelial rejection line, and subepithelial infiltrates are all signs of rejection we should look for. And a lot, they just mix up what's the difference between a codado dust line and just KPs. Now, a codado dust line is it's a line that separates the epithelium that has been compromised with the epithelium that is not affected. So it's that line that beyond it, when you see hairs, then all the cornea has been affected with immunologic reaction, and the other part where it's clear, then the rejection has not reached its effect on it yet. And the nearer to the periphery, the codado dust line, the more likely you will be able to control the rejection. The more into the center, you see the codado dust line. This means that it's the cornea, a lot of tissue of the cornea is affected by the rejection, and sometimes it's difficult to reverse it. This is just to increase on the to stress on the importance of the immune suppression. As we said, topical, a lot of use the topical cyclosporin. Actually, I'm not a favor of the topical cyclosporin unless I use it for epithelial rejection. Or if the eye is inflamed, or there's another cause of the inflammation rather than rejection. So if the patient has meibomian gland disease with inflammation, if he has an ocular cicatricial pemphigoid that's causing the inflammatory response, I would use topical cyclosporin. Otherwise, I wouldn't use it for rejection per se, because at its best, the efficacy is comparable to steroids. As we talked about tacrolimus before, and as we said, the immune suppression, they add on the benefit, and they do not replace the systemic steroids in the management of rejection. So as we said, you have to go to the rescue when you spot a rejection. You top up the drops, you use the IV steroids, immune suppression, you highlight the high-risk patients, and you allow them to come more often to the clinic, or to alert them about any signs when to check in. And in those with recurrent failures, you never give up, because there are other solutions on them, and especially those also with systemic illness. And I think I'm done with this. Mr. Liu, would you like to say anything?
No, I think you've covered everything.
Dr. Mazen, I think we would like to listen from the audience about any concerns regarding dealing with a failing graft, or any graft, actually, not only a failing graft or a rejected graft. What do you think?
Yeah, sure. Now, the audience, I think, have just started placing their questions. So meanwhile, I would like to, I would kindly ask you to summarize, like, let's say, to put guidelines when to remove the stitches and when to stop the steroids, because actually these are the major two questions that we face every day. For example, if a patient who is 25 years old after keratoplasty for keratoconus, so the cornea is not vascularized, the cornea was clear, and the reason for grafting is keratoconus. So now it is 6 months post-op. Do we start removal of stitches if the astigmatism is higher than 4.5 at 6 months, or we should wait?
Now, he's 25 years of age, you said, and he
Yes.
had 6 months since the keratoplasty.
Yeah.
Now, we do not tend to remove, now, before 9 months of transplantation, it is selective removal of stitches to serve a purpose, which is to adjust the refractive outcome. This is before 9 months, okay?
Yeah.
Because we have to secure the graft in place as long as possible. Now, if we have a very pronounced refractive outcome, like a patient who has a -11 astigmatism, we wouldn't wait for 9 months to adjust that, especially if it's against the rule or with the rule regular astigmatism, that we can adjust with 2 or more stitches. So a simple change in the stitch tone might affect the refractive outcome like this, but we do not tend to remove the stitches before 9 months, regardless if he's young or old. Now, after 9 months, if he's young and he has a 4.5 diopters, let's say 4 diopters of astigmatism and -2 diopters of myopia, I wouldn't touch the graft, actually. I wouldn't. First, because he's young. Second, because he has an astigmatism of -4.5 or -4. Because if I removed it, especially in the young, he would come after a few months with a doubling astigmatism rate. Okay?
Exactly. Why doubling? Because we are going to remove the stitches topo-guided. Okay, so we are not going to remove all the stitches altogether.
Yes.
So maybe we are going to remove 2 stitches here, then after 15 days, we will see the patient, then 2 stitches here. So why not to remove, even if it is less than 4.5 diopters of astigmatism?
Yeah, now we're talking about selective stitch removal. If you want to do a selective stitch removal to improve the refractive outcome, that's fine, no problem. But if you tend to, or you were aiming to remove all the stitches, and I mean all the stitches, this is the whole plan. We remove, if we decided to remove all the stitches for this patient, we go for like alternate stitch removal. We remove the first 8, and then we wait 2 months, and then we refract the patient and do a pentacam. And according also to the refractive outcome, if it's more or less than 4.5 astigmatism, we tend to remove the other 8. Now, sometimes you would do what you were saying. We would like remove 8 stitches. Everything would be fine. The patient would come after 2 months with 6 degrees of astigmatism, and we're happy to remove all the other 8 again. And then after a year or two, he would come, if he's young, he would come with mal-molded, let's say, cornea, a proud cornea at some place, especially if he's physically active, a young patient or athlete or officer where I work. They come usually with a proud cornea. Sometimes if they rub their eyes, it models and it loses the cohesion that we see. So the least I would do is I keep 4 stitches in place to hold the graft in young people.
Interesting. So let's say there are different ways to remove the stitches. There is not only one way. The one way is to remove it like topo guided, but after 9 months, of course. And the other one is to remove 8 and then wait for 2 months, for example, and then we decide to remove the other 8.
Yes, this is if the refractive outcome is regular and the cornea is doing well, let's say, and we are happy about what will happen if we remove all the stitches. Now, let me say it's always topo guided. Whether you moved 2 stitches, 4 stitches, or alternate stitch removal, you always do a pentacam. It's your right hand, let's say, or your left hand. It's the pentacam, because you remove according to it where the steepest meridian. Let's say you start with that one. You do not go to the best sutures and you remove them. You remove the ones with the most distorting the cornea. The steepest, yes.
But if you decide to remove, for example, 8 sutures, do you remove them in the other way, that to remove them all together, right? How do you decide?
Yes. I do a pentacam.
How do you decide? Yeah, let's assume that the astigmatism is with the rule, and it shows 5 diopters with the rule. All right, so -5 at 180. So which stitches do you remove altogether?
Okay, so -5 at 180, I would start. Now the all 16 are there, yes? I decided to go for, first I see if the -5 are caused by only 2 steep stitches at 180, then I remove these 2 stitches alone. Okay?
No, at 90. It should be at 90 because that's the steep.
If the tone, if the tone of the stitches is just equal on all the stitches, then I would start removing the one that is on the steepest meridian first, and then I remove the first one, and the other one is not. I don't remove it, and so on. So alternate stitch removal starting from the one on the steepest meridian.
Okay, so 1 at 12, then at 2, for example, and 10. So 3 up, 3 down. All right, so 6 stitches. Okay, makes sense. Yeah, thank you very much, really, because, you know, I'm, let's say, I love the astigmatism and imagination of the cornea, but you said that pentacam is mandatory. Suppose I have Cyrus. So we cannot do anything?
No, you can't.
It is a joke. It is a joke. Yeah, it is a joke. Actually, yeah, of course we can.
Yeah, of course.
No financial interest.
No, of course.
Yeah, great. What about the steroids? If everything is fine and the patient now is 9 months, or when do we start thinking of stopping the steroids? Now, everything is quiet.
The protocol that I use with all my patients is that we use topical steroids every hour for the first week after the transplantation, and then I cut it down to 4 times daily until 1 month. The first few months, like 3 or 4 months, and we see the patient first day, first week, first month, and then after 2 months, and we plan accordingly. Now, if everything is fine and there's no risk of rejection and there's no, let's say, a patient who had a PKP or transplant for keratoconus, after 4 months, I start tapering the steroids. Like he goes 3 months on 3 times daily, then 2 months on, or 3 months on twice daily, and then once daily until 1 year, let's say, and then once daily for life. Except if there's an episode of like a cut suture, a loose stitch, I ask him to top it up. This is if the patient is young. Okay, if he's
So once
old,
daily for life?
yes.
After 1 year, once daily for life?
Yes, if the patient is young.
Okay. And what about the cataract? Many patients may develop cataract because of this, of using the steroids.
A cataract is better than a rejected graft, more tolerable.
Yeah.
Once daily. How many patients have developed cataract with their keratoplasty? Actually, very, very, very few.
And glaucoma as well. But which type of steroids you put the patient for life after 1 year? Is it the same prednisolone or the Bridgeford?
That is not a yes.
But of course, with monitoring of the glaucoma, right? Development,
definitely.
IOP.
Yes.
Yeah,
definitely.
Professor
So I
Lou,
tend to use, I tend to use Lotamax, loteprednol, or softer cords, and they're a little bit milder than dexamethasone and Pred Forte, but they don't cause a pressure problem. And actually, topical steroids doesn't really cause so much cataract problem compared with systemic steroid. So I think it's worth paying that price, the risk of problems later on, because I think a graft, if it can, the survival can be prolonged, it is worthwhile, because if you have to reline it or put a new one in, it's often not as good. So we try and avoid it and just try and keep the graft going.
Okay, yeah, good. There was a question, then it disappeared from the mind. I will remember it later.
Maybe.
No, actually. Okay, let's see some questions from the audience. If the patient has lenticular astigmatism and the total axis of astigmatism, corneal and lenticular, does not correspond to that of pentacam, should we remove the sutures according to pentacam axis of astigmatism? It means that, do you take into consideration the pentacam astigmatism or the manifest or subjective refraction astigmatism?
Both. We have to take both in consideration, because you have to compare them and see. And when you compare astigmatism on the cornea or the pentacam, you have to take into consideration the anterior and posterior astigmatism when you are trying to manipulate or deal with the stitches. Now, lenticular astigmatism, if it covers or corrects for the astigmatism on the cornea, then that's okay. If it just adds on it, you can just ignore it, because and you have to deal with the stitches that are causing the astigmatism on the cornea. So
yeah,
but they have
now I remembered. Yeah, thank you. I remember the question. When do you consider the patient as young? We said young patients should stay forever on steroid. What's the definition of young? Below 40, above 40, 50, what?
I would say up to 50, 55 years of age is young. And I keep
good.
Them
thank you very much. So I'm still young.
Yeah, you are, of course.
Thank you. Great. Another question.
Yeah.
In this time of pandemic COVID-19, do you ask for SARS-CoV research in transplant?
What's that? You mean?
Do you ask for SARS?
Oh, SARS.
COVID research in transplant.
Does it mean? Do we test the transplant?
Yeah. It seems yes. Do you test?
We test it for COVID. Yes, we do.
Yeah, very good point. Let's talk a little bit about the criteria that you look for in the transplant when the bank sends you some reports. Okay, these are the options. Dr. Nancy, please choose one to send it to you. So, of course, we look for the endothelial cell count, the shape of the cells, hexagonality, polymorphism, so on. But what about if the patient died with cancer or virus, Epstein-Barr virus, for example, or other viruses, whether the patient was vaccinated or not? All of this will come in the report. When do you exclude this this graft from your choice?
Okay, now there are two criteria to consider or to reject a graft, an offered graft. Now, first, locally, which is to deal with the graft itself, which means the count. The higher the count, the better. But sometimes there's a low, not a moderate count, which is like 2,300, and then the specular microscopy in the examination is very good. So I would take that into consideration. It's not only the number of the cells in the endothelium. The second thing that I would like to look at, if I'm looking at a penetrating keratoplasty, if the reason of the transplant is penetrating, is the clear zone of the graft. It's always mentioned how clear it is. Sometimes it's the more clear it is, like 9 or 10 millimeter, the better. I try to age match somehow to keep the difference not more than 20 years. Just excuse me. And sometimes what I do, I look at the reason of death. If it is a disseminated malignancy, especially if it's, although this is it's okay and accepted for transplantation or donation, sometimes if there's a disseminated malignancy, liver cancer, if there's a blood malignancy or a neurological problem like death of unknown cause that we said because of the risk of Creutzfeldt-Jakob disease, I just discard it. One of the things that I want to mention is we do have 50% of grafts taken locally. Patients just they donated. Those who commit suicide, I noticed that most of the grafts, they just fail. And I stopped taking them for visual reasons. I couldn't find the reason. In one of the patients, I thought maybe the suffocation caused asphyxia, and this is what caused the graft edema. But then later on, as I just took grafts from other causes of suicide, I found that they fail so early. And I tend to tell the patient that why I'm rejecting this graft for visual causes. I'm not rejecting it for, I might use it like for a Boston keratoplasty. I might use it for as a tectonic graft, but not for visual reasons.
Very interesting. Actually, Jordan is a pioneer. I think it is the only Arab country that it has donation. It has its own eye bank.
Yes, we started that. Right? Yeah, one of the earliest countries in the Arab region, and I think late King Hussein he just initiated this in 1979. Actually, it's we're still young, but we're doing a great job, and it's providing like 50% of our needs from corneas.
Professor Lou, do you want to add something for the criteria that you select?
Yeah, you know, we're very lucky in the UK that there have been recently, there are fewer grafts available, but what they issue us with, they have already screened very, very carefully, not just from laboratory tests, but they take a history from the medical file and from relatives as well. So, for example, if there has been any neurological disease or they, even if they have tattoos, you know, that might be taken into consideration. And we get very, very high quality material. There are still some which get through the safety net. So, for example, patients who've had cataract surgery before, they're not really meant to be issued, but sometimes they miss the scar, and then when it comes to us, then we can see that there is a cataract wound, and that can, when I'm doing a DMEC, then it can affect the area which I can use. And also, there is no routine checking of corneal shape. So if a patient has, the donor has keratoconus or has had laser refractive surgery before, we don't necessarily know. And then that can end up with problems afterwards.
Interesting. Thank you very much. So back to the audience, our refractive target post PKP during first 6 months, better to be hyperopic or myopic? I think hyperopic, right, Nancy?
Actually, we don't aim at,
Yeah.
we don't usually aim. It's better to have, when we stitch or place our sutures during a PKP, it's better to align it as much as possible without tightening it too much, or because tightening it would cause flattening of the cornea, and then it's very difficult to redome it again, or making it loose and allowing it to, especially if you transplant a small button in a keratoconus patient who's already, the anterior chamber is very steep or deep. So we usually flatten if it's too keratoconic, let's say, or advanced keratoconus, but don't aim at a lot of flattening or hypermetropia because it's difficult to deal with afterwards, especially with stitches. So no special attention to being hypermetropic or myopic, but being as metropic as possible.
But I think this has a relation with the sizing of the donor and the recipient. So if the difference is 0.25, will be different from if the difference is 0.5, for example. Yes. If the difference is higher, I mean, if the difference is 0.5, so it will be flatter, correct?
Yeah,
smaller, you mean?
I think, so I mean, from my point of view, I think the three considerations. First is the how you cut the graft and how you prepare the donor bed. I think circularity is actually very difficult to achieve, especially for the recipient bed. So you do your best that you can. Normally, I actually cut freehand. So circularity, I just make a mark and then I use a 30-degree blade. And the other thing is perpendicularity. So the looking at the wound sideways, then you want to create a vertical cliff as much as possible. Now, the second is to do with sizing. So very much so that you can design the graft host difference in size to get a little bit less myopia or more hyperopia. So if you think about it, the keratoconic patients, although nowadays we're trying to do DALC as much as possible, if we're doing a PK, then nobody really does more than 0.25 more than the hole that you create. Some people actually advocate same size. And so there is an important point I want to make here, and that is you might use a 7.5 Trefine, but you don't actually know the size of the hole that you create. So you cut your hole and make it as circular as perpendicular as possible. But once you've cut it, then you measure it with calipers. And it is actually based on that. Then I go and cut my donor. I know some people will cut the donor before they cut the recipient, but the way I've been taught from my masters at Moorfields when I was learning, they always say, no, you prepare the bed first, see what you get, and then go and Trefine your donor. Now, when it comes to then don't forget, then for very young donors, they will have steeper cornea as well, and you have to be very careful when you are using a pediatric donor. And sometimes you might want to do that in an aphakic patient to create more plus power, but you know that's really that's very specialist practice. Now, when it comes to suturing, I think you want your suturing to be even and deep and tight, because when the sutures relax and after they're removed, then everything that you've put in there, as long as the tissue distribution is correct. And that's why, you know, in early part of the series, we say that the second suture is the most important because you're dividing the graft into halves. There's no point making loose sutures because you're just creating problems for yourself. The graft will not have healed, and then you need to go and resuture. So it's better to have tighter sutures. And if you need to, then you can do selective suture removal from very, very early on. If you've done one continuous suture, you can also adjust the suture by pulling more string to the area which is too tight, and therefore tightening the areas which is too loose. So these are things that you can use. So those are my strategies. I don't think we really aim very much. We just want a good wound and good apposition, good tissue distribution, and even and radial and non-torg suturing. Thank you.
Absolutely, thank you.
Yeah, thank you, Professor Lu. Yeah, very nice input. Another question: if a patient on bandage contact lens for bullous keratopathy and deep endothelial graft, and you suspected graft rejection, can we use topical steroids and keep the contact lens, or we should remove the contact lens?
Of course, we can keep. We can use topical steroids.
Yeah,
there's no problem because we use steroids even with the contact lens. That's not for bullous keratopathy. Does not interfere with the steroid drops.
Yeah. Do you think that the contact lens, Dr. Nancy, will play a role as a matrix? So it will absorb the medication and will make like a prolonged relief. So it will give better effect than without contact lens. Is there any evidence for that?
Sometimes the cornea, the contact lens works as a reservoir, it bathes the cornea with the needed drops, especially if it's permeable, of a good quality contact lens, of a good oxygen permeability. Then we can use it to bathe the cornea with the needed medication as long as possible, and it decreases the number of times we need to put in some drops on the eye.
So from my point of view, I think if a patient has had an EK, let's say a DMEC, I assume that's what the attendee meant when he said deep endothelial keratoplasty, because we don't really do DLEC anymore. So it's either DMEC or DZEC or DZEC. Then I think when it comes to bullous keratopathy, I think then the poor graft has really long gone down the pan, and the bandage lens is there to relieve pain, and really one should be looking at if after a while there's no survival, then you need to go in there and replace the DMEC rather than treat for a prolonged period of time if it's not going to come back. Now, in general terms, when there is a contact lens in place, it may retard penetration of eye drops, but it depends on the material. Of course, there are contact lenses which are already, for example, pre-soaked in antibiotics, and it could be used as a delivery model. One thing which is very important now for bandage contact lenses, which are replaced and thrown away quite rapidly, then it's not a problem. But if you use preserved eye drops, especially benzalkonium, that really does get concentrated in contact lens material, a soft contact lens material, and can cause a reaction in the eye. So with the bandage contact lens in place, it's best to use unpreserved eye drops. Thank you.
Yeah, great. Thank you very much.
I just would like to add something. One point, very important that Mr. Lu has mentioned about the importance of preservative-free drops on a corneal graft. Even if in the absence of a bandage contact lens, if you had a corneal graft with an abnormal epithelium, let's say, and usually there's a sloughing in the immediate period after transplantation. If you find that the epithelium is like hazy or shaky, or it's not just re-epithelializing quite well, or you're not comfortable about it, it's very important, mandatory to use preservative-free drops as much as possible in the first post-operative duration, because this will help a lot in the the survival of the surface, let's say, and the well-being of the surface.
Yes, I agree with you. I think if the surface looks bad, then I think preservative-free drops would be mandatory. But on the other hand, if it looks nice and shiny, then your normal Tobradex would do. I mean, at the end of the day, the with a PK or DALC, then the donor epithelium will gradually be replaced by the host epithelium. When the cells get shed when they die and with blinking, then eventually through XYZ, the host limbal stem cells will grow corneal epithelial cells back onto the corneal graft.
Mm-hmm. Yeah, perfect. There is a question, I think, related to a scar, how to remove a scar. In central corneal scar, trying a trans-PTK of 175 microns depth, trans-PTK with epithelium, he means, do you aim also to do PRK to compensate for the induced hypermetropia simultaneously?
I did not get the question. Is it?
Yeah, the question. There is a central scar. Let's assume that it is within the superficial 100 microns of the cornea, or 125, for example, and we are going to remove it by trans-PTK, and we are aiming to remove the bulk of the scar, but this will create, of course, hyperopic shift. So do you do
a transplanted cornea, a graft?
No, I don't think so. He means
cornea in general.
Yeah, in general. So do you do this, or do you do the PRK to compensate for the hypermetropia? Well, I can answer this question because actually with corneal scars, the refraction is unpredictable. We cannot predict the real refraction of the patient, and we cannot predict the amount that we have to compensate for after applying the trans-PRK. So usually we do this in two steps, in a two-step procedure. We do the PTK first, and we tell the patient, of course, in advance that we have to wait at least 3 months for the cornea to rehabilitate. Then we do the refraction, and then we can decide which best refractive surgery suits this patient. Okay, I think.
So, Dr. Sinjo, I think that's quite interesting. 175 micron depth. That's quite deep, and you have to remove
this
a
is what
lot
I
of
want to
teeth.
say. Would we go 175?
Yeah, that's quite deep in the central cornea. And also, the central corneal scar, is it causing any distortion of the corneal surface? If not, and it's opaque, then maybe the patient doesn't actually see it, and maybe it's bothering the surgeon more than the patient. And if it doesn't bother the patient much, then maybe we should leave it alone.
Yeah, exactly. So it depends, yes, how much it affects the function, of the vision. Okay, that's amazing. It was a very nice session. I think if we stay receiving questions, because it is a very interesting topic, and we have the two stars, Professor Lou and Dr. Nancy, of course, we will stay until tomorrow morning, but we don't want to, the dinner is waiting for Professor Lou, as usual, right?
Yes.
Okay, thank you very much. Of course, dear audience, we will announce within a couple of days for the 2022-23 for the new series of Cornea, with plenty of very interesting topics, including surgical procedures. So all these questions will be addressed on time, and you can, of course, be with us and ask as many questions as you like. So I'd like to thank Dr. Nancy for this lecture, as usual, and Professor Lou for giving the time and for the remarks and guidelines. Thanks to the audience as well for being with us, and have a good night, everybody.
Merry Christmas. Bye.
Thank you. Bye-bye.